today we are going to talk about pain management and some red flags at primary care and low resource centers. Actually, the whole country is in a low resource center at the moment. So I think it is applicable to each and everyone as medical officers in the country currently. So today I'm going to talk about pain definition very briefly and how do we feel pain. That is the pain pathway, because we have to refresh our knowledge a bit. And what are the pain types? Is it important to know? And how to manage different types of pain in our peripheral setup or in our units? And what are the drugs in hands and their effects and side effects usage in very brief, and common presentation to our centers, the chronic backache and what are the alarming features, because we sometimes treat backache but the underlying cause is somewhat else. And little bit about cancer pain, because you will come across these patients very often, and I want to emphasize what are the resources to us to get a good pain relief, because it's a very painful or very depressed situation, cancer pain management. And what are the obstacles at the moment we are facing in the management of pain. So you know that in your medical school also, we don't like to talk about or study about pain. Pain is a pain. And the definition also, it's somewhat long definition. But I have to tell something about this, because this is the International Association of Study of Pain definition. Though it is not very useful in our day-to-day practice, we have to know the components. So it defines as pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. That was the earlier definition, and they have added some more to this definition, but it says that it can be influenced by various biological, and social factors, and pain and nociception are two different phenomena. We'll talk about that later in detail. And person report of an experience as pain should be respected. So that is the working definition of pain actually. A person's report of an experience as pain should be respected. And it may have adverse effects on function and social and psychological well-being. That is what it says is the pain affects all the functions of the body. And another important factor is that inability to communicate does not mean that the person is not having pain. So that what it means, even infants, neonates, or cognitively impaired people have pain though they can't communicate. So that is important addition to the previous definition, because sometimes we undertreat them thinking that they don't feel pain, right? So though it is very long, our working definition is very short. If the patient says hurts, that is pain. So we have to respect what patient says. We don't have right to say you don't have such pain. It can't be. It is not you are corner or you are malingering. So we don't have right to say like that. There are people, very few, but most of the time, if the patient says hurts, that is pain. That is our functional or practical definition of pain. So if I go through the pain pathway a little bit, you know that nociceptors are peripheral free nerve endings. You get stimulation from that. And afferent nerve fibers, the first order neuron goes to the dorsal horn. And from there, the second order neuron ascending after crossing the opposite side as second order neuron in the spinothalamic tracts, and it is to the thalamus, and there's a third order neuron. So though it is a very simple diagram, the pain is not very simple pain does not go in a simple pathway. It is very complex. There are a lot of descending fibers, gate control theory, and so many things, so many receptors, chemical transmitters involved in the pain pathway. So, in fact, that is somewhat beneficial because we can manage pain effectively if we identify those receptors and chemical mediators and all, and we can modulate this pain pathway effectively. So, in one hand, it is a beneficial or added advantage to have different receptors. And the other thing, there are descending fibers, though it is not drawn or shown here. There are descending fibers from the cortex or the thalamus to the dorsal horn, which will modulate pain. Mostly they are inhibitory fibers, so we use them in management of pain. So this is the normal nociceptive pathway. And when I'm talking about the neuropathic pain, I will tell what are the differences of the pathway occur in neuropathic pain. The other thing, nociception and pain perception are two different phenomena. It is not same. So in practically also, one person with a small pinprick will show enormous or unexpected, unexplained or exaggerated response, right? So why is that? If the pain stimuli is equal, why they feel different types of severity, or the grading of the pain perception is different? Because they have so many influences in the cortex which will modulate this pain nociception. So beliefs, either religious or psychological factors like anxiety, depression, anger, those things, and cultural issues like expectations and other illnesses like cancer, person's personality, and social factors, all will influence your pain perception. So nociception and pain perceptions are two different phenomena. So you have to address that when you're managing pain effectively. So are all pains the same? No, they are not the same. The pain is one umbrella, but it has different components. Usually, if you ask three main questions from the patient, you can categorize the patient's pain either of these groups, right? So how long has the patient had been on pain? So in that sense, you can categorize basically that pain is whether it is acute or chronic. Sometimes you will encounter that pain is acute or chronic. That is, the patient has some basic pain, but on top of that, patient has gotten another severe attack because of some reason, right? So it is easy. If you categorize the pain, then your management will be easy. So what is the cause for that pain? Either it is a cancer or non-cancer. And what is the pain mechanism of this pain? Nociceptive or neuropathic or mixed type of pain. We'll talk about that later in detail. But at the moment, from today onwards, once a pain patient has come, you ask these three questions from yourself and try to ask questions from the patient to reveal what category of that pain. So any pain hereafter, either acute, chronic, or acute or chronic, it could be cancer or non-cancer, nociceptive, neuropathic, or mixed type, because it is easy to manage this type of categorization or classification. So acute pain is pain of recent onset and probable limited duration. But a chronic pain, by the definition, if the pain lasts more than 3 months, it is categorized as chronic pain. And pain lasting after normal healing, usually we allow some time. If you take a operating scar, after surgical scar, you know that this should heal or should be pain-free after this period. But if it is going more than that, it is called chronic pain. And sometimes no identifiable cause, right? So that there are conditions like chronic regional pain syndrome. There's type 2. There you can't find a cause, but the patient complains pain. Sometimes there may be a very minute or trivial injury. Patient cannot remember, but the pain persists. So we also tend to say, well, there's no injury, no history of anything happen. How can he get pain? But there are circumstances. So no identifiable cause, but there could be pain. And cancer versus non-cancer, it is easy and it is obvious for everybody. Cancer is a patient is having a diagnosed cancer, and if they don't have a non-cancer pain, then it may be different any other cause, and it could be acute or chronic as well, right? Because some would say, what this is silly, cancer or non-cancer. It is not very useful, this categorization. No, because the selection of drugs, our management strategies differ when the patient is having cancer and non-cancer, especially when we are using opioids. So nociceptive pain, that is pain we always, most of the time we all have experienced, right? Usually it is a good pain or a protective mechanism, and it goes through the normal pain pathway. It's obvious tissue injury or illness is there, and we call it physiological pain, and it protects you. If there's pain in the lower abdomen and you go to the patient comes to you, you may find patient is having appendicitis. So that is a good pain. And myocardial infarction, if you get pain, you're lucky. Sometimes you die, you don't feel pain, you don't know you have got a MI, silent MI, and you drop dead. So pain is a protective mechanism, and it goes to the nociceptive, normal, the pain pathway, which I have shown or we have refreshed in our knowledge. So this pain, you can't ask patients whether you have nociceptive pain. You have to ask questions to find out whether this is nociceptive. So you ask, how you feel pain? Then the patient will explain sharp or dull pain, and the cardinal feature is it is well localized. So myocardial infarction, the pain is retrosternal, sometimes radiation, but that it is if it is retrosternal, the most probable diagnosis or differential diagnosis. If it is hypochondriac pain, maybe acute cholecystitis, with the site, there's something, and so patient will say well localized, or patient show the pain is here or pain is there. So nociceptive pain is such, and we'll move to neuropathic pain. The other component or the counterpart of the nociceptive pain. So what is neuropathic pain? Maybe this topic is new for some people, but you may have heard it, but not very much familiar. So it is caused by a lesion or disease of the sensory nervous system. So when your sensory or pain pathway is also got pathological changes like neuroma formation and so many, there are receptor abnormalities, there are range of the wide dynamic range fibers and so many things in the pain pathway, they are get altered. The primary sensitization, secondary sensitization, nerves crosstalk. There are so many pathological terms explain this neuropathic pain. Anyway, it is not physiological. It is pathological. Your pain pathway also sick, right? So then the pain sensations also different, right? You won't feel dull or sharp pain. You can't say from where it is coming from. The patient will show it is coming from this area and it is tingling, electric shock like burning. Sometimes they say the insects are running. We had a patient recently, he's always rubbing uh, his shoulder, saying that uh, Kubikanava. So that sort of terms they come across. So we'll think whether this is a psychological problem. No, that is how they feel it. So neuropathic pain is somewhat funny and it is not helpful. It is not a physiological, and it is a useless pain, right? So you have to ask from the patient, how do you feel your pain? Is it something? Sometimes patient won't think that is a component of pain. So specifically, you have to ask, do you feel this? Do you feel electric shock like burning or itching and those features, right? Unless you ask specifically, they won't come out. They won't think that it is something wrong in the pain pathway. Because I emphasize on this part, because neuropathic pain is we are managing very differently. So once you come across a patient with pain, our basic approach is rat approach, right? You know rats everywhere. So pain is like a rat. It is difficult to control sometimes, right? You know the rats in the house. There are sometimes you can't find them where, and but you can use easy or simple measures to control that. Cages or a cat will solve the problem, right? So pain is also like that. Sometimes it is all over everywhere, but you can control if you assess or approach it in a systematic manner. So my attempt is how to approach this pain in a systematic manner, whatever the low resources you have. So first thing is recognize. Actually, this is from Essential Pain Management Program, which is launched by uh, Wayne Morris in Australia, and he has designed a program, and it is using all over the world, most of the countries. And in Sri Lanka, this EPM program we are conducting by the College of Anesthetics, the Faculty of Pain, island-wide, and any one of you can join a one-day program with a certificate, and more than the certificate, you will get a very good knowledge and management skills with this program. So in that one, we manage, first we recognize pain. So somebody think, what is recognition? You know that patient is in pain. Yes, but you have to ask from the patient, are you in pain? And the recognize means you have to know whether the other people at home or the surrounding people of that patient knows that he is in or she is in pain. Because the person in pain needs support. So we have to know whether the other people also know that the patient is in pain. So recognize means the patient as well as the other people know that the patient is in pain. So assessment is the main component, because unless you assess the patient very well, thoroughly, in detail, the management is not possible, right? So assessment is very, very essential, and I'll put more weight on that in the next few slides. And we'll talk how to treat. I think you know the treatment most of the time. The only thing is that how to assess and how to categorize and how to select the drugs correctly in the management of pain. Right, in the assessment, we use in this medical school also. So I think we use the mnemonics. Socrates is an easy mnemonic to assess pain, right? Site, from where it is coming, and onset. Is it important? Yes, because we categorize it as acute or chronic. So onset is very important, from when this started, right? And character, whether that character means whether you have nociceptive features, neuropathic features, or whether you have mixed type of features, and any radiation, associated symptoms, and duration for how long. It's basically goes with onset, and any exacerbating factors, and the severity. So severity is equally important as the onset, because unless you assess the severity, you can't reassess the patient and get the idea whether the patient has got relief or not. So why can't we say patient? Why we use a very systematic way of assessment? One thing is that it is easy to communicate. If you want somebody convey the or get opinion from some other person, it is easy to use a pain scale or some objective measurement tool rather than subjective. Rather than saying mild, moderate, we are using that. I'm saying it is wrong, but it is more specific if you use a scale, right? So we are having unidirectional scales as one, which I have shown you, the numerical pain scale and the facial pain scale both together. And they are called dimensional, right? That is, you're assessing the pain severity only. And multidimensional scales that you assess the patient's behavior, basically how the pain has affected the patient's life. Especially in chronic pain conditions and cancer pain, we use multidimensional scales, right? So in the beginning, I said that infants, neonates, and children, cognitive impaired patients, all are having pain. Sometimes they are not able to communicate. So how are we going to assess their pain in a sub-objective manner? We can. There are different tools, like flat scale and so many scales. I'm not going to talk about that because time is limited, but you should know that there are ways to assess their pain, right? So what I have shown is the one we are using commonly, and you can go to the internet and you can see so many scales, and this is one easy way of assessing scale. So what we say is 0 is no pain, and worst pain possible is number 10. Right? Somewhat like labor pain or myocardial infarction pain. So 1, 2, 3 is somewhat mild. And that is a pain that settles with simple analgesia. 4, 5, 6 is not settled with simple analgesia. So you need something else like weak opioid or something to control that pain. So 7, 8, 9 is somewhat severe, and you need more drugs, strong opioids to control. With the explanations to the patient, most of the time they will give the number correctly. We are working in a pain unit, so each and every patient, we ask, what is the number of your pain score? Then they will, once we teach them, they will take. So even in your center, you can use this to assess pain. Then, if the patient doesn't know the numbers, the phases are there, from face to crying or very horrible depressed face, and they can select what is their face or their emotions like, right? So especially the children, they can respond to that. So in addition, this severity assessment, we have to take a good past medical history, drug history, because there are drug interactions, it is not a new thing. You are practicing medicine, so you know that it is very important. Any analgesics at the moment, what patient has taken and what are the response. And allergies, social family history, because this pain sometimes goes with any problem in the family, especially uh, in the GP practice. I think sometimes pain is not the reason to come to him. Pain is not a big issue at the moment, but they might feel pain more because this depression or anxiety goes hand in hand with this pain. And how the pain has affected the person's daily activities is also very important. And patient's expectations. Sometimes, especially the cancer patients, we know patients expect to work, the short lifespan, they want to be with the family, they don't want sedation. So there are such things. So patient expectation. We have to ask that question, what do you expect from me to do, right? The other thing is there's something called at rest and functional. Why we bother about that? We want functional pain score less than 3 is the pain relief margin or the target. So we want to take pain score less than 3 at the functions or with movements. So that is what we expect. So I'm not going to talk about what are the bad consequences of pain. You all know that, so I'll skip that part. And so I'm going to treatment or the management part because the time is limited. So this treatment and management, why there are two terms? Because we can treat acute pain most of the time because we know the cause and we treat the cause at the same time. But management is somewhat different. We cannot cure chronic pain conditions. We manage them, right? We manage the patient's day-to-day life somehow, and we keep them comfort somehow, but you cannot cure them. You cannot treat completely to relieve pain. They have relapses, they have remissions. So it is something called management, right? So this management or treatment is pharmacological as well as non-pharmacological, right? So surgery would be a non-pharmacological method, and physically you can use, we call it RICE, rest, ice, compression, and elevation. So the mnemonic RICE we use most of the time in pain patients, right? Acupuncture, massage, physiotherapy, these are also helpful. I'll talk about that later. And at which point in the pain pathway we are using that. And psychological explanation, reassurance, and counseling are very important aspects in chronic pain management. So we talk about the pain pathway, and why? Because I said that at that point also, as there are so many centers, so many receptors and neurotransmitters, we use them, we catch them at different points to stop sensory propagation to the brain, right? So in the peripheral level, as non-pharmacological, we can use rest, ice, compression, and elevation, and we can use anti-inflammatory medications and local anesthetics to stop signal propagation from the first order neuron. And in the spinal cord, we use acupuncture or massage. They all affect your gait control, and we can use it effectively. And local anesthetics, opioids, and ketamine, we are using at the spinal level. And in the brain, the psychological impact or the pain perception can be changed by talking to the patient, by cognitive behavioral therapy. I'll talk what is CBT later. Those things will help to modulate this pain at cortical level. And your paracetamol and opioids, your mu receptors are there. They can be blocked with these drugs. So basically, what we know that we categorize the pain: acute, chronic, cancer, non-cancer, and nociceptive neuropathic or mixed. So why we did that, and also why we assess the severity? Because our management is easier once we assess those two. So WHO pain ladder, I think it is not a new one. You all know this, but we are not using it sometimes. We have forgotten it. So always easier to go to according to a format or a protocol. Then you can use your drugs effectively, and you can save your drugs as well, because you don't need unnecessary loading the patient with high-fi things if they have mild or moderate pain, right? You always try to give the minimum drugs and try to control their pain. So we call the step 1 as mild pain. Your pain score 1, 2, 3, and non-opioids like paracetamol. So simple analgesics will be enough, right? Simple analgesics and NSAIDs. So opioids or moderate, step 2 is moderate pain, and sometimes it can be managed with your simple analgesics plus weak opioid. The severe category 7, 8, 9, and 10, they need strong opioids. But simple analgesics has a place in all steps. This is initially developed for cancer pain, and we are using this in chronic pain as well. And there's another component or a drug group called adjuvants. I'll come to that later. Sorry. But acute nociceptive pain, we use the reverse WHO ladder. That is, it is not necessary to go from 1, 2, 3. Depending on the severity, you have to select the step and either go up and down if you are on step 2, or you can straight away start on step 3 and come back. Right? You know that if the patient is having myocardial infarction, no one is going to give paracetamol. So you're going to give morphine. So patient is in the severe pain, right? It is not a thing to think twice, right? You straight away go for morphine, right? So that is, you without knowing, you are using the WHO ladder in a reverse manner, right? So our target is, as I said earlier, bring the pain score down as soon as possible, whatever the means you have, and you step down or you de-escalate your management once the pain settles. As in sepsis, you use broad-spectrum antibiotics after culture, and you de-escalate or step down the antibiotics once you have culture reports, right? Likewise, pain. Once the severe pain is settled, you break the vicious cycle, and then you can use your simple drugs or step down, right? So your trauma pain, post-operative pain, your myocardial infarction, renal colic, right? Acute pancreatitis, they are severe pain conditions. So you straight away go to the step 3, give morphine, and then once the patient settles, come back to the lower steps, right? And chronic and non-cancer pains, right? So again, we use the same cancer pain ladder, WHO ladder, and there, the non-pharmacological treatments are very important, right? And patients, I said that there's another drug group called adjuvants. So adjuvants come into play in neuropathic pain and cancer pain very frequently. So sometimes We are not very familiar with these adjuvants, but they are very useful drug group we can use in these patients. And opioids, without knowing, sometimes we used to give or we are trying to prescribe, but it may cause harm, right? Opioids are not recommended in chronic pain conditions unless it's a cancer because of this addiction, tolerance, and dependence. In fact, it can cause harm because it modulates the pain pathway and can cause harm. So it is not recommended to use opioids in chronic pain conditions. But in cancer, yes. So cancer pain, you know that cancer pain is multifactorial. The origin would be multifactorial. The primary tumor itself, the necrosis, edema, tissue compressions, capsular stretching, and all that can cause pain, right? And the intestinal obstruction, ureteric obstruction, the nerve root innervation, metastatic disease, cancer treatment, surgery, chemotherapy, all these cause pain, right? And on top of that, the procedural pain, all are tolerated by the same patient. And it is progressive, it is dynamic, and usually moderate or severe. And a lot of psychological elements are there. The depression, anxiety, separation, and currently the patients having a lot of economic problems, all those things we see within this cancer pain. So it is not a simple or single entity. It's a very big problem to the whole family. If there's a cancer patient, the whole family is suffering. So it is, if you're a good pain management person, you have to solve most of the things. Therefore, these non-pharmacological and pharmacological measures are equally important. We are mainly using opioids in cancer pain. And it is not a single person show, it's a multidisciplinary teamwork. I touched that one. If you get cancer patient, you may have to talk to us, you may have to talk to the psychiatrist, social workers, physiotherapists, so many, and sometimes religious person. So it is not a single person managing process, right? So that's why I added that slide in this lecture, because you are the first, maybe the first person encounter such a patient in your vicinity or in your village, in your hospital. So you have to refer them or at least get advice from these groups. So it is a multidisciplinary teamwork. Anyway, pain management is multidisciplinary, but especially cancer pain and chronic pain conditions need others' help. So drugs, what are the drugs in our hand? I'm not going to talk about paracetamol. You all know that. And Panadine or paracetamol with codeine 8 milligrams, they are called simple analgesics, and NSAIDs. Everybody is familiar with those drugs. The only thing that I want to emphasize is NSAIDs for long-term use is not good or not recommended for years and years. Sometimes we see them, but you have to reduce or you have to take it off as soon as possible as patient settles. So NSAIDs precaution, the asthma, sometimes patients will show exacerbation, but asthma is not a contraindication to use NSAIDs. If they are okay with NSAIDs, you can use. But if the patients are long-term diabetic, hypertensive, or any renal impairment, though their creatinines are normal, they have some sort of renal damage. So chronic conditions like especially diabetic and hypertension, you all know the main causes for CKD in the country. So NSAIDs, you have to use very carefully. The side effects, the gastric irritation and all that, platelet counts, the patient is on other antiplatelets, so you have to select the patients very carefully when you are using NSAIDs. But it is very effective in acute pain conditions. And weak opioids, you know that tramadol and codeine available in the country. Tramadol is a weak opioid, and codeine syrup is available in some places, but it is not very commonly available. But if you need, you can find it in the country at the moment. But you know the strong opioids. I don't know what are the opioids available or very easy to use in your center, but pethidine, morphine, and fentanyl are the commonly used drugs. And sometimes we have these drugs, but we are afraid of using. The nurses are afraid of using, especially morphine. They like pethidine. They are very fond of giving pethidines, IM and your Phenergan. They are very familiar and very happy to use it. But morphine is another drug that you can use if you are in a ward. If you have morphine, don't be afraid. Use morphine, especially even IV. The dose is 0.1 milligram per kg. If the patient is 60 kilos, his normal dose is, I'm talking in a severe pain conditions, not in mild or moderate pain. But you can use IV morphine if the patient is in a ward. If you have oxygen and bag and most of the medical wards have resuscitation facilities. The dose is 0.1 milligram per kg, so his dose is 6 milligrams. So we are not going to give straight away 6 milligrams. We can start with 3 milligrams and see the blood pressure and how the patient responds to pain. Then we have to stay with the patient, but within 5-10 minutes, patient will show the response. Then you can give another 1 milligram and see what is the patient's pain relieving dose. The other thing is that if the patient is not responding to 6 milligrams, what are you going to do? Are you going to give more? Yes. There's no maximum dose or there's no ceiling effect. So morphine, the patient will respond. We don't know what is the patient's dose actually, right? Basically roughly guided by 0.1 milligram per kg. The only thing is that we are not going to give that straight away. We can give small quantities and see. If you are still afraid of giving morphine IV, can give subcut morphine, same dose, and see. But the subcut route is sometimes not promising, maybe erratic, depending on the patient's blood flow and all that. But still effective. You will see the effect in 15 to 30 minutes, right? So what we call respiratory depression is once the patient gets good pain relief only, then if you give further, then patient can go into respiratory depression. We call respiratory depression if the patient's respiratory rate is less than 8 and patient is drowsy, the pupils will small. So in that case, naloxone is the antidote. Most of the hospitals have naloxone. If there's a theater, usually there's naloxone. So it is 400 micrograms in a vial. You dilute it up to 100 mics per ml. That is, dilute up to 4, and you can give 100 mic at a time and see. Because it is immediately patient will respond and the respiratory depression will settle. The other problem is naloxone is short-acting. So you may have to repeat the dose or you have to start naloxone infusion. Fentanyl, usually it is not very familiar in the ward, but theaters, of course, yes. But it is very short-acting and very quick action. So therefore, fentanyl is very effective to get pains go down very quickly. The morphine is not a dangerous, it's a group of dangerous drugs, but if you know the how to control it, you can use effectively, especially post-operative pain, trauma pain, and any other myocardial infarction or whatever the severe pain condition, right? So these are the drugs usually we are using. And always you should know the side effect of these drugs and you have to treat it. If the patient is on long-term drugs, the patient should know what are the side effects of these drugs, at least what can cause drowsiness, what can cause nausea, vomiting, what can cause constipation, and so on. You have to tell the patient and you have to give the drugs to counteract those side effects. Otherwise, your treatment will cause further problems on the patient. So always tell the patient, if you get this is the drug causing that, stop it and come to me. And these are the drugs I am giving you to settle your or solve your constipation. These are the dietary advice. We are very reluctant, or we are taking very little time to talk to the patient, but pain management is not easy to do without talking. At least sometimes we take nearly 1 or 2 hours for one patient, right? So you have to tell the patients the side effects and give the drugs. That is very, very important. So adjuvants are the drugs that made initially for something else, but you are using it for analgesic. Antidepressants like amitriptyline, venlafaxine, duloxetine, and anticonvulsants like GABA, pre-GAB, carbamazepine, and NMDA receptor antagonist, ketamine, lignocaine, local anesthetics, bupivacaine. We are using those things for pain relief. I'm not saying all these can be used in your setup, but there are drugs these groups are using in the pain management units very often. Clonidine, dexmedetomidine is not available, but dexamethasone, buscopan, baclofen are available in our setups. And tizanidine, I think it is available in the private sector. So the antispasmodic sometimes, most of the time, or muscle relaxants like baclofen, we are using in the pain management. If I talk a little about amitriptyline, it's a tricyclic antidepressant, but we are using very minute dose like 12.5 to 25 milligrams nocte. And it is a very cheap drug, especially in this neuropathic pain. We are using these adjuvants, your gabapentin, amitriptyline, duloxetine, venlafaxine. They are very often used, right? The dry mouth, drowsiness, urinary retention, though it says like that, it is not very prominently seen in the patients because we are using very small dose, because these are not the antidepressant dose. It is very low than that. If you talk about gabapentin, its maximum dose is 1,008 milligrams per day in long term, and if you are using short term, I think it can go up to 3,600 even. So, but we are not using that much in our long-term use. So you can nociceptive pain, neuropathic pain, cancer pain, whatever the pain type, gabapentin is a good drug, right? Even post-operative pain you can use. Panton limb pain, yes, you can use. Cancer pain, yes, you can use. It has acute, all the pain types response to gabapentin. Especially it has opioid sparing effect if we are used with opioids in cancer pain, right? So it's safe, effective, but there are side effects as well, drowsiness, and dose needs to be increased very slowly. So you start with 300 milligrams, day 1, 300 BD, day 2, 300, 3 times thereafter. Sometimes very slower than that. And if the patient is in renal impairment, be careful, all the drugs, go through the BNF and correct the drug dose according to the EGFR, because they are accumulating. Especially the morphines can get accumulated because they're active metabolites. We often come across patients when sometimes they get AKI, and especially cancer patients, and they get CKD or renal impairment due to chemo drugs, and all of a sudden they are drowsy. So, but I think in your setup, though they are not in that extremity, the renal impairment is a thing that you have to keep in mind always, especially these patients, those who are long-term diabetic, any nephropathology, long-term hypertensives. Though the counts numbers are normal, they may have renal impairment, right? So that I want to emphasize. And ketamine regional techniques, lignocaine infusions, patient control analgesia, nurse control analgesia, and transdermal root patches are available in the pain centers. I'm saying I added this slide not to practice in your center, but you can select the patient or you can choose the patient who need these services and you can refer them. There are pain institute in National Hospital, Kandy, Gaul, the doctors driven or the consultant driven pain units are there. You can talk to these centers and send the patient, refer the patient to these centers if they really necessary. So being a pain-free person is a human right. So we have to respect the human right? So these things I added because you can uplift their life with these things. That you can pick them up and call us or refer them. You can get the hospital, and through the hospital you can call us. I personally am available at any time to answer if anybody call from anywhere in the country. Especially sometimes my colleagues call day and night sometimes for opinions, but I'm happy and I really appreciate it. So we are there to help at any time. Only thing that I cannot manage non-cancer patients in our hospital, but we can advise you to refer to this center or the particular hospital for the further management. So non-pharmacological, if I talk a little bit, there's cognitive behavioral therapy, mindfulness, yoga, relaxation, acupuncture. If you have these yoga, relaxation, acupuncture near your centers, you can refer them or you can talk to these people because these are helpful. I said that pain pathway has ascending as well as descending fibers. These descending fibers are modulated by these things. Cognitive behavioral therapy is somewhat that patient is educated or trained to live with that pain. That doesn't mean that patient lives with suffering, but he change his mindset and they will be able to have a better life with your pain drugs once they are in the cognitive behavioral therapy. So the psychiatrist or the psychotherapist can help that. The other small part, I think we are about to close this session, finish this session. Chronic back pain. It's very common presentation in your PP or your hospital in your centers. So most of the time it is non-specific or idiopathic. So no point of trying to find the cause. And mechanical or referred pain are small entities. The thing is, you have to find why this patient is having pain, right? So there are so many reasons to get backaches, but most of the time it is non-specific or idiopathic. Still, you have to see these features. They are called red flag markers because you are the first person to come across these patients. If the patient is less than 20 or 55 years of age and significant trauma and progressive thoracic pain and cancer or steroid therapy, IV drug abuse, and unexplained weight loss, unwell, the coda symptoms and structural deformities, and lumbar flexion is very limited and non-mechanical. If those patients having these features, you have to refer them. The backache is a sign of something serious underlying condition. So barriers, either personal knowledge, lack of knowledge, wrong attitude, wrong facts, attitudes, and inadequate staff. Resources, yes, equipment and drugs. As a country, currently, we are in a very crisis situation in that sense, and legal issues, especially when you are handling with opioids, right? But above all, I think the main barrier is attitude. Attitude is everything. So if we change our attitudes, we can do a better service. If we think this patient is one of my family member, right? My mother, father, or my colleagues, sibling, or a child, we will give more human touch. It doesn't mean that we are not doing that, but it will give a more added gravity or added weight to the patient's pain. As I said earlier, it's a human right, basic human right, so we have to respect it. Right? My take-home messages: always respect the patient's complaint and try to find the cause, because pain is something. Pain is the tip of the iceberg. That's something big under the water. And rational use of drugs. As I said, if you categorize, you can use rationally most of the drugs. Correct time, correct dose, and correct patient around the clock, right? And pick them up and refer if needed for drugs or any interventions. And it is a multidisciplinary teamwork. It is not a one-man show. And show empathy always to these patients, right? Imagine you are in that situation and how do you feel? But you show empathy, but you should not involve emotionally. So that is also important, especially when you are managing cancer patient. If we involve emotionally, there's no life for us, right? There are so many sad soul stories. We have to listen them. You show empathy, but not emotion, right? I think any questions are there?
If we find red flags in a patient in a divisional hospital, resource poor center, what to do? What is the next step?
You can straight away refer them either surgical or medical clinic, or else you can talk to the consultant. Even as you are in the divisional center, you are the only person, you have access to the base hospital or the thing, and straight away refer that patient immediately. But you have to manage the acute pain, but explain the patient, and we can refer. But anything else?
Yes, thank you, madam. Yes. And another question: are there any contact or hotline to contact in an emergency regarding pain management?
There are, especially in our unit, we have a hotline. Our cancer patients use that, but it is not accessed by the non-cancer, or island-wide access is not there. But there's no national hotline or anything such. But any hospital, as I said, Maharagama, NHSL pain unit, through the hospital you can contact and get advice. Even now, so many doctors calling me in the day and night. Sometimes, can I get advice for this patient? And I also ask my colleagues, I got this type of patient, what can I do for this one? I have done this and that. So we also not managing individually. And my other colleagues also calling me, even NHSL consultant, and I call her, or I call senior one, some other doctor. So you can call. Anesthetists are there. If I say, doctor, is it possible to me to say names also? In Kandy Hospital, especially Prasadini Hospital, Dr. Samananakara, Gaul, Dr. Gihan Pirsiri, and Chinko, Dr. Anupa is there. Kandy, there are a lot of people, Dr. Ashani Ratnayaka, Dr. Roshina Malavarachi, and Dr. KDU, Professor Tamasi Makulolu, and Dr. Gaini Alfola, the former Apeksha hospital consultant. I know personally, and Dr. Lakshman Disanayaka, the head of the faculty at this transplant unit, Maradan. So they are available. If anybody needs any help, we are there. And me at Apeksha, we are available at any time. So if anybody needs any help, we are there to help you. But there's no hotline for everybody to call and get advice or assist 24 hours.
Thank you, madam. And there's one question online. Can you please describe about management of backache?
Backache, it is not easy to describe in this situation because it takes time. As I said, it is most of the time mechanical pain, musculoskeletal. So you have to get a proper history, proper examination, and sometimes you may need investigations as well, CT or MRI, full neurological examination. Then you have to see what it is. But basically, simple analgesics or especially NSAIDs will help to reduce that moment pain. Especially if it is in acute stage, we are not advised to do physiotherapy and all that because it can cause further harm. So it's mainly if it is an inflammatory condition most of the time or the nerve irritation, then you can use simple analgesics. So tramadol, even weak opioid, and NSAID if it is not contraindicated, and non-pharmacological measures like hot and cold fermentation, and there's a place for gabapentin and baclofen or dexamethasone sometimes we use to relieve the acute stage, but you have to see why it is, and you may refer orthopedic or neurology if there's anything, and especially if there's focal neurological signs, numbness, sensory impairment, bowel and renal, urinary incontinence, and if the patient is very young with severe pain and any history of, as I said, the red flag signs, code equina signs, which is emergency, neurological emergency, you have to refer them as soon as possible. Did I give answer to that question?
Yes. Thank you very much, madam, for that interesting and very informative lecture and answering all our questions. And thank you very much again.